Thank you so much, Dr. Ibtisam. So we'll move on to the Q&A right now. We have a lot of questions. And thank you for Dr. Carla and Dr. Nikki for joining us. So Dr. Ibtisam, maybe we can start out with your first talk regarding hirsutism. So you mentioned the use of spironolactone and oral contraceptive pills. So what I typically notice is that spironolactone is started and it's usually kept at a 25 milligram dose. Do you tend to increase the dose? And the second part to that, how do you decide on the oral contraceptive pill? Do you have any preference regarding progesterone estrogen ratios?
This is again a very good question. I did not have time to go into the dosing, but usually you start with 25 milligram of spironolactone and you should titrate the dose. Don't keep the patient on 25 milligram because this is a lower dose. Usually the required dose is up to 100 to 200. And in regards to the oral contraceptive pill, usually in common practice, Diane is recommended as it also have combination of cyproterone acetate with the hormones. So that if you combine them together, then you will get a good result. Yeah.
Thank you. Professor Dalal, I think you have a question.
So I forgot to answer the next question. You said how to judge the body response. Yeah, the response is judged, first of all, you have to keep in mind that the response does not take place immediately. You have to wait at least 3 to 6 months and should warn the patient about this, and they should be compliant on treatment. And the judgment is based on the Galloway scoring, as well as the time the patient spent in removing the hair or the hair regrowth. Yeah.
So I'm going to direct my question to Dr. Nikki. Fantastic talk as usual. I have 2 questions about steroids in the context of apoplexy. Are we doing this for ocular palsy in addition? Is this going to have an impact on developing panhypopit or no influence it whatsoever? And because we're giving this to avoid central adrenal insufficiency in the acute phase, how long will we continue and when will we start taper and re-challenge and retest?
Great, thank you for the questions. The first one, I assume, is about offering extra steroids for the anti-inflammatory effect, because I'm not sure if I got the question correctly. Is this what the question is about?
I was wondering if it has an impact in reducing risk of panhypopit, or just to improve ocular palsy in this context.
Okay. I will start with the ocular pulse, maybe, or maybe I go one step behind. Why do we offer steroids in acute apoplexy? There are 2 potential reasons. One is because we think, we assume that the patient may have developed adrenal insufficiency, and therefore the patient needs steroid cover because this is a stress situation. The second reason, which is debated by a lot, is offer steroids because they have anti-edematous, anti-inflammatory action, and therefore by this way we may prevent the pressure effects from the mass that is developing there. I don't use steroids for the second cause as a main target. I use steroids as a cover for potential adrenal insufficiency. And therefore, if there is ocular nerve palsy, in my practice, I don't use steroids. There are no studies, there are no trials which inform us as to whether offering dexamethasone, for example, in preventing further consequences of the swelling that develops there. Now, then the question is, if we offer steroids, if the patient does not have adrenal insufficiency, are we promoting the development of secondary adrenal insufficiency? I think we have to balance the risks and benefits. That's number 1. Number 2, we will recheck the patient anyway at 6 weeks and we see what happens. Number 3 is that cortisol deficiency may be progressive. We may do a random or a morning or whatever cortisol when the patient presents to us with apoplexy. It may be a not bad value, but we don't know what happens in the next few days. So we have to keep our patients safe. In our practice, we offer 50 milligrams hydrocortisone IM as a shot then for a couple of days, 50 milligrams 4 times daily, IM. And then with taper, we go to oral, gradually reducing, and when the patient is discharged in a few days, he or she remains on the usual physiological replacement. And 6 weeks later, we will do our assessment to see the axis. So that's our practice, and I hope I answered your question.
I think we have another question from the audience.
Dr. Ibtisam, in your prolactinoma presentation, the metabolic syndrome is the most common, especially these days, and this insulin resistant is the most common. And you mentioned, do you use cabergoline if the patient wants to be pregnant, or do you use life reducing weight and the rest? And what is the size of prolactinoma? Do you get prolactinoma? Have you seen prolactinoma in metabolic syndrome?
No, you get hyperprolactinemia in metabolic or polycystic ovary disease syndrome. You have mild, yes, you have mild elevation of serum prolactin, and it's not recommended to treat them with dopamine agonist. And the treatment for polycystic ovary disease or metabolic syndrome with hyperprolactinemia is you treat them with the usual way. Depends also on the symptoms, whether they are concerned about ovulation, hirsutism, or they want to seek pregnancy or not. If they are not seeking pregnancy, then the treatment is with weight reduction, and in addition, if they have ovulation or menstrual irregularity, you may give them oral contraceptive pill with probably anti-androgens plus metformin. Metformin would be good in such patients, even if they don't have diabetes or they have pre-diabetes.
But if she wants to be pregnant?
If she wants to be...
Pregnancy?
Yeah, but again, metformin will help in the insulin resistance, but I don't usually recommend giving them cabergoline because what you are treating, you are not treating, as we said, you are treating only the level, you are not treating the symptoms. Yeah.
We have another question from the audience.
Question to Dr. Ibtisam regarding macroprolactinoma that cause pressure on the optic chiasm, and start to giving her medical treatment in hope that you avoid surgery. So after starting the treatment, how soon you are going to bring the patient for another assessment, and how quickly you escalate the dose, and when do you decide that medical treatment is not working and to refer to surgery?
Thank you very much for this question. Actually, macroprolactinoma, we should handle it carefully as well. As I mentioned, maybe I did not have more time to spend on the algorithm, but if you diagnosed radiologically macroprolactinoma, then you assess the prolactin level, usually with giant tumors or big tumor, usually the level is above 500 nanogram up to 1,000. If it is lower than this, like maybe 100 in the mild or moderate, then as I mentioned, you should rule out, first of all, the hook effect. Okay, and if you ruled out the hook effect and it's still minimally elevated, then probably this is a non-functioning pituitary adenoma. Okay, so probably the response may not be adequate to dopamine agonists. So probably they are candidate for surgical treatment, alternate treatment, especially if they have optic chiasmal compression. However, if it is prolactinoma and they have levels above 500, then here you can try the dopamine agonist. I usually start slowly. I start very slowly for the sake of the symptoms to reduce the side effect in relation to the treatment. Cabergoline would be better than bromocriptine, and you do it slowly. I don't do it very fast. I have seen cases going into apoplexy as well, so I don't really do it dramatically. So I do it slowly, especially if the patient does not have optic chiasmal compression. And if they have optic chiasmal compression, you may assess the patient closely for response, because usually they respond quickly to dopamine agonist. As I mentioned, some of them maybe even within 48 hours. However, if they are still symptomatic within the first 4 weeks with no response in the serum prolactin, then probably you should, and you have already escalated the drug, then probably you should seek alternate treatment.
Thank you. Dr. Riam?
Thank you. I have a question to Dr. Carla. I really enjoyed your talk. Very nice data you presented. In the era of precision medicine, do you think we can avoid those consequences to the endocrine system by choosing the medicine and the patients and predict what's going to happen?
Thank you very much for your comment, for your question. So I think, some people have looked at the presence of autoantibodies, so the presence of thyroid autoantibodies, and whether the pre-existence of these antibodies predict what people will go on to develop thyroid dysfunction when they receive these medications. And some studies do suggest that if the autoantibodies are positive prior, that their risk of developing thyroid dysfunction is much higher than those who start off with negative thyroid autoantibodies. But even having said that, even people who have negative autoantibodies still have quite a high frequency of developing these side effects. So I think it's not quite possible to predict who will develop these. And so unfortunately at the moment, we still have to continue to screen everybody for these potential side effects.
So if I may follow up on that, Dr. Carla. So you mentioned in the talk that those who do have autoimmune complications may have an improved prognosis. So can you elaborate a bit on that? And to follow up on that, is there a role for checkpoint inhibitors in pituitary cancers, adrenocortical carcinomas, thyroid cancers, so those that are related to the endocrine, since we know they are affecting endocrine organs?
Yeah. So yes, so this suggestion that those people who develop these side effects may get a better outcome from their cancer is very interesting. And again, it's not quite clear cut. So there was a nice meta-analysis published a couple of years ago looking at approximately 5,000 patients who developed these side effects. And curiously, the patients who developed the endocrine and skin side effects were reported to have increased overall survival and increased progression-free survival. But that was not the case for other side effects, respiratory and GI. So it may be that the people who develop endocrine side effects, you know, they may be the ones that especially have improved survival. But having said that, people can respond very well to these medications and they may not develop any immune-related adverse effects at all. So I think there's a signal there, but I think that it's not entirely clear-cut. And I think that when we think about the use of these medications going forward, as each year goes by, there are more indications for these medications. So yes, I think definitely with time, these are going to be looked at in more details for all sorts of cancers. And I think the list of indications and the types of cancers that benefit from these treatments will certainly grow.
Thank you. Dr. Ahmed.
Yes, first I would like to thank all the three speakers for excellent presentation. And my question is to Dr. Abtissam. Dr. Abtissam, it's a practical case. A patient's referred to you, seen by another doctor who did an MRI for a prolactin that is slightly elevated, probably in the 40s nanogram, and looks into something suspected to be a microadenoma and started treatment with Dostinex, with cabergoline. No symptoms, except the patient telling you that since I took Dostinex, I felt better. There was headache and it's gone. What do you do?
This is a real scenario that we get often, and it has many parts of it. First of all, we have heard today morning about the incidentalloma, and I've just also stressed on not to do a radiological imaging before you really confirm that the patient has symptoms and really hyperprolactinemia, with ruling out other causes, because there are many other causes. You have to repeat the test. It's not just only one test and then I go and do MRI, because it could be either incidentalloma, small incidentalloma, or it could be even, if you repeat the MRI, it happens that we repeated the MRI or CT scan and then said there is nothing there. So probably if the patient is asymptomatic, she has regular menses, she does not have hirsutism, she does not have any other signs, probably I won't do anything. I would reassure the patient. If the patient is anxious, I know some patients really are anxious because of, sometimes they get messages from other doctors that they have a problem and they get really concerned about this tumor. I may repeat the, for example, MRI or CT scan in 6 months or 1 year. And the response to Dostinex, you mentioned that she responded, she said she felt better. In what way she felt better? Some of the patients, they may get like psychological improvement rather than a real improvement. My assessment, if the patient has irregular menses, she has galactoria, she has hirsutism, and she improved, then probably this is related to the treatment. So I hope I was able to address, or if you have anything you can also discuss with us.
I would say somebody like you, a good doctor, will convince her that that diagnosis was wrong, and you start stopping and tapering the Dostinex.
Absolutely.
That's what I did, actually.
Absolutely, but I've seen in my patients really sometimes they get really very stubborn and they believe, especially if they are given a drug and they have told that they will be better on that, and they get the impression, the psychological impression that they are better. So probably they will keep shopping, going from another doctor to another. But I will be very happy if she is convinced, and I will explain to her the radiological findings. I will explain to her everything that she does not have symptoms, and if she is convinced, that would be good. I will not even repeat the MRI.
Thank you very much.
Dr. Nikki, we frequently see patients with pituitary macroadenomas, and how do you counsel them about headaches in terms of, is there anything characteristic about a headache for pituitary apoplexy that makes them need to go to the ER? Is it the severity? Is it the location? What about the headache should raise signs?
Okay, the headache of a typical pituitary apoplexy, and I emphasize and I mentioned that in my talk, this is a clinical syndrome, is very, very characteristic. The patient describes it in a vivid, in a very robust way, a very heavy, sudden headache, as if a hammer hit me, the patient says, on the head. So it's not the very daily headache or the unilateral headache like migraine or whatever. It's sudden onset, which is really strong, and the patient has not experienced something like this before. This cannot be really missed. And we are talking about typical pituitary apoplexy.
And one more question regarding basically patients who have apoplexias. I think you mentioned it in your talk, but if you can elaborate a bit, so what percentage of them who are treated conservatively have either tumor progression at follow-up, if they're treated conservatively?
Okay, if they are treated conservatively, the range, there is a wide range of progression, and this depends on the duration of follow-up. That's why I gave a range. I wouldn't give you a specific number, because normally we need to do Kaplan-Meier curve and take into account the duration of follow-up. But yes, it is something that can come up.
Okay, thank you. And Dr. Carla, one question. So I actually have a patient on pembrolizumab who's been having episodes of hypoglycemia. Cortisol is fine, thyroid function is fine. Is there a reason for these drugs to cause hypoglycemia?
So obviously the first thing that would come to my mind there is adrenal dysfunction. You've mentioned that the cortisol level is fine. I'm not aware of any association with hypoglycemia. Obviously, there's a rare association with diabetes, as I've mentioned, but I'm not aware of them causing hypoglycemia. I mean, I suppose it is possible that they could develop novel autoantibodies. So that would be something potentially that could cause hypoglycemia, but I haven't come across that.
Thank you. And Dr. Sam, maybe one last question. So one rare side effect, but a very, very serious side effect of cabergoline is impulse control, pathological gambling, hypersexuality. And I've actually seen a patient who suddenly started gambling off cabergoline. So do you ever counsel your patients when you start them about these rare side effects?
I do usually, but I just counsel them about the common side effect. I keep telling them all the possible side effects, some patients, they may get those side effects as well. So I just tell them about the common side effect, like the dizziness, the nausea, and the vomiting, and why do we need to titrate the dose slowly. However, rare side effect like this, I have not seen any case like this in my practice. But if it happens, then when the patient comes to the clinic, then we have to explain that this would be a possible side effect, and probably we taper the dose and probably change it to another drug.
Thank you. Yeah. Dr. Wiam?
Yeah, this is my last comment. Thank you again for the presentation of Sam. The question that you raised, that there was a study from the UAE, and prolactin is caused sometimes by PCOS. This is very controversial. The Endocrine Society have said it clearly that there is no association between polycystic ovarian syndrome and prolactin. I actually wrote an editorial in the Journal of Diabetes and Endocrine Practice with my friend Ali Khalil and Huda Izzeddin about this issue. And they clearly state in the Endocrine Society that you should look for prolactin causes. It had nothing to do with polycystic ovarian syndrome. This is just a comment, and I think we should look into this because the cause and effect is not well established.
Yeah, probably I think we should look for it carefully. But I mean, how would you do that? I mean, if the patient has like mild hyperprolactinemia, probably we should look for other drugs. What would you suggest doing? The problem is, again, if we do like MRI of the pituitary, then we end up with incidental findings. So probably what I will do, I'll treat as insulin resistance and then monitor and repeat again the serum prolactin. As I mentioned, stress itself can elevate the prolactin. We have other causes. It's not necessarily the polycystic ovary disease. It could be other non-tumoral, non-pituitary hyperprolactinemia, like stress, venipuncture, exercise, whatever is the underlying cause. So, but in all cases, you don't treat, right? We don't treat. Both are, yes, extremely common disorder, yes.
So with that, I'd like to end the discussion. I'd like to take this opportunity to thank Dr. Carla, Dr. Nikki, and Dr. Ibtisam for wonderful lectures. We wish you were here in person, and hopefully in the future you'll come visit Bahrain and we'll get to speak to you in person. Thank you so much.